Dr. Lee is going to present training resident versus training surgeons. Should they be trained the same? Thank you, Dr. Lee.
Chairman, thank you for the introduction, and good afternoon, ladies and gentlemen. It's a pleasure here to participate in the IFSES session. The task of looking at training residents against training surgeons. Next. Once quote by William Halstead that we need a system, and we surely have it, which will produce not only surgeons, but surgeons of the highest type who will stimulate the fine youth of the country to study surgery and to devote their energies and their lives to raising the standard of surgical practice, which was quoted at the beginning of the century. And are we doing that? In fact, there's an interesting original article from Surgical Endoscopy of questionnaire of general surgical residents. And it's actually found these are residents who are either candidate member of SAGES or attended SAGES resident course before. And it looks like they all feel that they need for additional training in advanced laparoscopic surgery. So obviously, there are a lot to be decided. And I'm very sad to hear early on our previous speaker said the fellowship program is going to be taken away because of lack of industry support. The focus group in ASCRS, in fact, they have a very, combined with SAGES, a very mature program to do colorectal surgery training. And they come up with guidelines for colectomy course. And they have a very good program of advocating basic module for people interested in doing colorectal training and to advanced module. The basic module consists of didactic, porcine lab, basic skill, procedure lab, and then didactic and cadaver. And so really they should be having training in all these structure before they move on to doing human surgery. And the basic module training, they actually listed out the requirement of the course director, got to be certified, got to have himself 50 laparoscopic colectomies. And the participant qualification as well also have had previous laparoscopic experience. And for the advanced training model, they also have come up with who should be trained and what's involved in using in the training course, particularly the use of cadavers. And these are the brief conclusion of laparoscopic fellowship and the learning curve that they come to agreed on in different authors. And you can see here, this is for colectomies. And you really have a wide range of number of cases of reach competence in these articles. But you do need a high volume case with experienced mentor to do this teaching. Well, we have a little different system in Hong Kong. In fact, we have incorporated laparoscopic surgery, basic module, and advanced module into our residency program. So for our trainees in Hong Kong, before they get their fellowship, they've already been taught on basic and advanced laparoscopic skills. Generic, not specific disease-based, but to us, the basic skill would be doing a pancectomy and cholecystectomy. And for the advanced module, they will be taught on acute cholecystectomy, perforated ulcers repair, and possibly some sort of bowel anastomosis. So by this time, these chaps, when they finish the residency program, when they move on to the advanced program of subspecialty interest, be it colorectal or hepatobiliary, they already got the basic on their hands. And the training program, we have designated director to coordinate the training, followed by a mentorship program. And not just that, they have to demonstrate competency by having a logbook record of numbers of conversion, complication, troubleshooting, demonstrating of minimal access surgery. And of course, reaching a threshold of number of procedure. And followed by accreditation for general and advanced procedure. And the training module we have for colorectal surgery, again, require the fellow who comes in for colorectal surgery training as a subspecialty, their basic knowledge of laparoscopic skill, and then get them starting training with simulators, training at porcine cadavers, then followed by training at accredited laparoscopic center before they reach their fellowship recognition. And this is establishment of our training center since 1995 with the official territory-wide health authority training center for minimally invasive surgery. And this, we've been running these programs for the last 15 years. And this is currently the training center that we have built specifically for this purpose under the support of the health authority. And for established surgeon who should have acquired basic laparoscopic skill, means having the simulators training, followed by training with simulators, like this particular one here with the Promus doing a colectomy module. Not just to complete a task, but the surgeon's movement recorded and analyze positive feedback for movement. These are the interesting thing about the modern simulators. And with this, we also use, instead of using live animal, we use organ perfusion model, which was very useful because you get away from the difficulty with having license and things. So we've been using this POP module for simulated pigs, organs, intestines to train people for the last 15 years. And of course, we have updating our knowledge with the academic meeting. So why not all-in-one a structural organization with these sort of training? Well, this is exactly what we do for Far East. Sego Kitano and myself have been involved in the Asian Endoscopic Task Force looking at training at surgeons, not residents, in all over Asia. And how do we go about doing this? Well, we started off with a mission to what to do, and we actually started this work in 2005 and making use of facilities in Japan and in Shanghai, which are the lab facilities. First of all, obviously there are live animal models in these situations for the specialists. And this particular one is a model on colorectal. And they get a training course of a live animal model. This is actually the training video where we share with the trainees before we start the surgery on the experience. And of course, we have lectures and live demonstration of surgery. And you can see here every single courses is recorded, indexed, and digitalized in DVDs. And we can have this on the web where it can share by all the attendees, for people who are interested and can log on and see all the detailed courses. And really, these are the kind of program that we've been running. In particular, one I'm very proud of is actually, besides attending courses, this is a particular picture in Philippine General Hospital where I went and proctored the university hospital by mentoring them for the first year before they start their colorectal program, which is now very successful on its own feet. So laparoscopic fellowship is attending formal laparoscopic training fellowship, which shorten the learning curve and improve the clinical outcome for patients. I'm sure all of you agree with that. But the training orders is important. We need competence in basic procedure, satisfactory completion of advanced procedure. Availability of experienced mentor at the beginning of the learning curve is important. Hands-on training in a high-volume center, and perform minimum number of procedures to sustain the acquired skill. Caution, of course, completion of training does not necessarily mean clinical competence. So training against competence is important, and this is really looking at the various aspects of training. So besides training, we should grant periodic renewal of privileges, adequate volume procedures, objective measure and procedure outcome, participant in education and quality improvement activities, and continue recertification. So in conclusion, credentialing is important to ensure quality. It provides recognition of professional and technical competence. Training and demonstration competence are essential, and post-training proctoring and continuous monitoring of performance are important to maintain standard. I thank you for your attention.
Thank you very much, Michael. Beautiful presentation. I will announce you that Professor Michael D was elected as the counselor and executive counselor and secretary general and treasurers of the IFSES at this time. And he has served as the next four years as the congratulations.